And so it's a real honour to have Greg Fell here, who's been battling away at that front line as Director of Public Health for Sheffield over the last 2 years ago. But before I kind of formally introduce Greg, I just wanted to say a few words about the Pemberton Lecture. So this is our 10th Pemberton Lecture. It's our annual public lecture in Shire, and it's named after Professor John Pemberton. And John was an epidemiologist. He died in 2010. He was an epidemiologist who worked in the field of social and preventative medicine, and specifically on topics of nutrition and industrial disease, and how they relate to poverty and inequality. And if we think now of what Shire's become, health inequality and how we deal with health inequality is a core theme of what Shire does, and that's a real legacy from what John was doing those many years ago. And so it's a real delight to be able to introduce this Pemberton Lecture this year. Now, Greg is somebody I've known for quite a long time. We trained together in public health in the mid-2000s. He went off to work in Bradford in 2009 and was there till 2016, when he came to Sheffield. And we've kept in touch, and which has basically been an occasional email from Greg to me telling me to get a proper job, which I've resisted. But when I emailed him about this and asked him how he'd like to be introduced, he said he gave me a kind of completely random list of thoughts, which is very Greg. One of which was he's got a real love of death metal, and he has the best wallpaper in his house. So despite him being a public health giant with 18,000 odd Twitter followers, he certainly doesn't take himself too seriously, which I always think is just a great attitude for a public health leader to have. So it's my great pleasure to welcome Greg to this year's Pemberton Lecture.
Thanks, Mark. Some of those things are actually true. So I'm going to thank you for the welcome. Thank you for coming on an icy night. And I'm going to talk for about 40 minutes, 45 minutes. I'll try and get through my 765 slides in that time. You can have the slides afterwards. We'll make them freely available, so you can do with them what you will. So the title is there, and I'll talk about the pandemic. There's been a pandemic on, don't you know? The threat is real. We'll talk about pandemics. We'll talk a little bit about public health. We'll talk about the long shadows and what comes next, which will be interesting. Or the subtext is what it was really like being in the middle of a public health emergency. I hope the public health emergency of our lifetimes. If this wasn't it, then I dread to think what the real one will be like, and give you a sense of what it was like being a DPH in a medium-sized city in Northern England in that context. Any DPH in the country can tell you exactly the same story there or thereabouts. Contact details at the bottom of the slide. I've got a phone number, but I never answer it, so don't try phoning me. I've been known to spend a bit of time on social media. So what I'll talk about, a little bit of context setting, public health in local government, what, when, where, who. There's been a pandemic on, don't you know? I'll talk you through the anatomy of the response, the who did what. Some thoughts, leadership and lessons and learning, 22 months in and counting. It's not over yet. Anyone that thinks it is woefully mistaken. As I say, I'll talk a little bit about the learning and lessons to date, and then back to normal, whatever normal might be. I think it will be a new normal. Firstly then, public health in local government. So I've been in Sheffield now for nearly 6 years, and I asked my boss on day 3 of being DPH, I said, John, so I've got this job description, it's 27 pages long, I don't understand it, it's written in HR language, you do, don't you? And John said, oh, of course I don't understand it. So he downloaded it off the internet. What do you really want? And this was the answer he gave me. Think about the public health function, so the things that go into public health, health leadership, whatever that actually is, and don't ask me because I might not be able to define it. Health improvement, so all of the things from sort of the things that we call lifestyle, term used advisedly, choices, term used very advisedly, right the way upstream to sort of the social determinants of health, rats, drains, jobs, poverty, etc. health intelligence, how well we describe how healthy we are or not, health protection, which kind of became quite important over the last 2 years, but has always been important, and still some significant responsibilities around NHS and social care. John said, job one is to pull all of that together into a coherent whole and be the DPH for the city. We do your pay and rations, Greg, but you're there to act as a DPH for the city. Second thing he said to me was the budget. The thing that's known as the public health budget is 33 and a bit million quid. It's the core public health services, health visiting, sexual health services, drug and alcohol treatment services, tobacco control, obesity, etc. could go on. And then other, which is a vast array of all sorts of stuff that covers all manner of interesting things. That's arguably the budget that you have executive control over, but I want you to think of public health as a function for the city, something much wider than the budget. Takes me back up to the first bullet point. So his ask of the leader of the council was, she said, Sheffield Council is a public health organisation. John said, she means it. She doesn't quite know what she means sometimes, so your job is to help her articulate what that actually means. So what happens in housing policy or economic policy is just as important, maybe more important, as what happens in NHS and social care policy and service delivery. John extended it further. John said basically everything that happens in this town affects our health positively or negatively. Please sort. Just don't care how you do it, just stay out of jail. Which was John's job description to me, which was quite a liberating place to be. Easy to say, hard to do. Why does public health exist? The purpose of public health I'd put to you is in those four graphs. For those of you that have to do things like joint strategic needs assessment, that's a JSNA in a single picture. Roughly in order, the gap in healthy life expectancy between the east and the west. A man born in Darnall tomorrow can expect to live a third of his shorter life than a man born in Dore, who can expect to live a seventh of his longer life in a state of good health. Neither fair, right, or just. And arguably, that's the single most important thing. Obviously, it's an issue for NHS and social care demand. Obviously, it's a social justice issue. Obviously, it's an economic productivity issue, because if you have a diabetic heart attack age 50, you might not go back to work. And then you get into a whole bunch of stuff around poverty, ability to feed your family and all of that kind of stuff. Second graph on the top is multimorbidity, rather a spin on the healthy life expectancy story. But if you cut that way, there's about a 20-year difference in the onset of multimorbidity between the most and the least affluent. Or if you cut it that way, at any particular age point, there's about a 15 or 20% difference in the prevalence of multimorbidity, which is one, more common in working age people than the elderly, and secondly, is more common. Multimorbidity is more common than single illness. It's more common to have 3 or 4 things wrong with you than just one thing wrong with you. So again, matters for all sorts of reasons. Third is the stalling life expectancy. COVID will have had a big impact on life expectancy in the last year. I've not yet seen the data, but it will have had an impact on life expectancy. But the real big story is now it is flatlining. It's not just happening here. It's happening in pretty much every town in the country. It's happening across the world. Life expectancy is not going up anymore. That's major news. And obviously, there's also a gap between the haves and the haven'ts, the most and the least affluent, black, white, disabled, not disabled, however you want to cut that gap. And we often revert to geography as a proxy for poverty, but it's not just geography. Last one is infant mortality. Has been going down for decades. Spectacular good news story, public health wise. Is now going up again in the most deprived. It's still going down just about in the most affluent. So that's the purpose in a single slide. I'm going the wrong way. Hopefully I went the right way. If only we knew what would make a difference. This isn't a problem. Public health isn't a problem of not knowing where to focus our energies. We know exactly what to do. The global burden of disease survey is really, really clear. Cigarettes, tobacco, alcohol, obesity, diet, blood pressure, cholesterol, etc. We know why we have avoidable health problems. You can cut right the way upstream and talk about that in the context of the determinants of health. Poor air quality, poor quality housing, lack of access to green space, etc. You can cut that in any number of different ways, or you can go life course, which is when you can, you know, this isn't a problem of not knowing what to do. We broadly know what to do. Keep going the wrong way. Organisation and framing. Sheffield, certainly, this is, you just about recognise it's a bit out of focus, the Hallamshire, spectacularly valuable institution, but our orientation and framing of public health isn't hospital demand working backwards, it's this stuff working forwards. And I'd put that, and I say frequently, the inequitable distribution of all of that stuff and more is way more important to health than all the IAPT and the statins in the world. Not that IAPT isn't important and not that statins aren't important, but these things are arguably much, much more important. And that's the way in which we orient our approach. Everything's in. The question is how far upstream you go. Do you go illness? Do you go risks and risks to poor health and assets for good health? Causes of health, causes of health. Ultimately, you get kind of up here, austerity, neoliberalism, and the equitable spread of power. Ultimately, that's about as far upstream as you're going to get. But this is the space of probably naked politics, which is a difficult space for an officer of a local authority to be in. But arguably, if you're in an everything's in type of context, and you want to get to the heart of things, then some of the stuff at the bottom of that list is arguably the most potent space to intervene. Enough of context. There's been a pandemic on, don't you know? Anyone not know that, just in case you've missed the memo? So I presume you all knew that. We knew it was coming. This has been my third pandemic of my career. It will not be the last pandemic of my career. I hope it's the most serious, but it definitely won't be the last. And we knew it was coming, and we knew the run-up. So the run-up, a number of exercises were done, are principally around pandemic flu. We were anticipating, and the National Risk Register said pandemic flu was likely to be the thing. That's a copy of the pandemic flu plan. It's on my desk still. Hasn't proved to be terribly useful, actually, and I'll come on to that afterwards. And it still says under review. It's never quite finished. But we did do a number of exercises in the sort of the 5 or so years in the run-up to the eventual pandemic that broke out in early 2020. The key things, roughly in order, and you can read as well as me, so I won't read them all. The most important two things were business continuity and social care. Very, very fragile, very fragmented, very atomized market. Business continuity, if a care home goes kaput, that leads to all sorts of downstream consequences. So that was a big issue. And if a care home is basically running on very skeleton staffing infrastructure because a third of its staff were off isolating or off poorly, then that makes running social care really, really, really difficult. So the critical business continuity question to every business was, can you operate your business on 5, 10, 15, 20, 30% less staff for a sustained period of time? Big NHS institutions probably could, though it's been a hell of a struggle. Smaller social care institutions struggled a lot more, actually. PPE, supply chain, logistics supply was very, very, very tricky, and thus it proved. Planning around excess deaths, the handling of bodies, how big mortuary do we need? A huge amount of energy and emphasis was put into that in the planning stages, and actually, as it played out, that worked pretty well. So I won't read the list, but arguably we did do an awful lot of exercising for pandemic flu. The lessons from that proved pretty useful, actually, when we actually got to the acute response to COVID. Arguably, we ignored some of the critical lessons until we actually had to deal with it for real. Come back onto that. We went into the pandemic in pretty bad shape health-wise. So Marmot, 10 years on, was published in February 2020. Spectacularly bad timing because nobody was interested in it in February 2020. We all had other things to do, which was an emerging crisis in Southeast Asia, which by February 2020 was spreading across the world. So the Marmot 2020 was the first big indication that the life expectancy story had fundamentally changed, and there were now no longer year-on-year improvements. So that was an important piece of contextual evidence. One second piece was something that was only published relatively recently by Ben Barr and colleagues out of Liverpool, the impact of local authority spending cuts on life expectancy, and he didn't go there, but almost by definition, healthy life expectancy, kind of directly making a correlation between the long-term trend in local authority funding, which pays for the things that you call the determinants of health, transport, so good quality housing, etc., and health consequences measured by life expectancy. And Claire Bamborough's group published a wee bit before Ben Barr, which was the the long-term trends in healthy life expectancy over 2 decades. And actually, one of the things that Claire and colleagues set out was life expectancy is now decreasing in many places in England and Wales, which is clearly big news for all sorts of very, very obvious reasons. The links are in the slide, and you can read them at your leisure later. We went into the pandemic in bad shape public sector-wise. Public sector 50% smaller than it was a decade ago, ditto the welfare system. That has consequences. We ignored the lessons of some of the exercises. That kind of had consequences, but we caught up. We certainly had a hollowed out and distracted by Brexit civil service, and definitely hollowed out public health capacity and capability. The IFS have published a lot on that. And you know, the PHE were a lot smaller, and local authority public health were a lot smaller than they were, say, a decade ago. So we've got to include all of that in the post-match analysis when that comes, and that will come, hopefully soon, but maybe not as soon as any of us want. So all of that kind of matters by way of the context. So the flow of the pandemic, and as I say, it's not over yet. So this is the flow as of nearly the 1st of December, 22 months in. It's 29th day, isn't it? Nearly 2 months in, and it's not over yet. Timeline, firstly. Something's happening in Southeast Asia in December 2019. Remember it well. I remember looking at what was going on in Wuhan, thinking, going to need to keep an eye on that. And I remember a call with a colleague and said, you're going to need to keep an eye on this thing in Southeast Asia, the Wuhan flu, I think we called it then. Remember those days? He said, it'll probably not amount to much. Note to self, don't make predictions, because they're always wrong, because it clearly did amount to much. But we kind of began to prepare with some quite meticulous preparation for just in case it really went big from late December, early January onwards. Vividly remember a call from Jenny Harris, who was MDCMO, on a Sunday. I was out walking the dog I think it was early February 2020. Greg, there are some patients from the Diamond Princess cruise that we're repatriating to the Hallamshire. You're going to need to know about this. And as unsurprisingly, these were known as the first Sheffield cases. They weren't actually Sheffield cases. Clearly, they acquired their illness on a cruise ship. But they were in the Hallamshire, world-class centre for infectious disease. Therefore, the media went crazy. That led to very long period of intense preparation, which was probably January to March. Setting out our structures according to the pandemic flu plan, knowing full well it was a coronavirus, but we'd done the work around pandemic flu. It broadly served us well, but but it wasn't a flu. It was a coronavirus, and our note was higher than we'd anticipated. Led to a lockdown, and then obviously that led to a very long and very intense response, with the continual shift and nuance of structures, policy, and operational delivery right the way up to today, and then some. I think we'll be here for a little bit longer to come. And there's a whole bunch more detail about the sort of the detail of the policy, which I can send you at leisure. But these are things that we will pore over at great length when we get to the post-match analysis. The whole course of the pandemic is in this. Well, whole course of the pandemic up till mid to late October. It's been updated a little bit since then. Is in the slide here. This is Sheffield data. Grey is the cases, so people with a positive PCR test for SARS-CoV-2. You can see here. Who'd have thought exponential growth would be a thing? Who knew what exponential growth was before we got here? We all know it now. We've learned the hard way. Hang on, it's not the whole course. There's another graph which I haven't got, which goes back even further. The two things to note off this graph. One, these two lines. First dose, second dose of COVID vaccine. Clearly, we started in December. We started with the very elderly, and then worked out to pretty much the whole population. I think we're currently down to 12 and plus. First and second doses are now flatlining. We've got about 70% of the population vaccinated. What's of note is the orange line is deaths. So we've got very high case rate now. There, we're about here now actually. But now we've got 70% of the population vaccinated. We've got almost no deaths. So that's a fabulous vindication that vaccines save lives. Who knew? Whereas here, a really high case rate and actually really, really high deaths in terms of per day. There's about 1,400 people have lost their lives, sadly, to date. And that will creep up a little bit. So we can see the whole course of the pandemic, and the EPI team in my team, aka the Public Health Intelligence team, have tracked that for us and have done actually a really, really good job. And that's enabled us to make reasonably fleet of foot decisions about how to deploy the operational response, because there's a whole set of machinery in terms of operational response, and then our policy approaches as an organisation, as a council, and as a city to opening, not opening, running certain types of events, etc. So I'll do. This is the pattern of the. Let me just run this whilst I talk. Pattern of the pandemic across the city. This is. I'll start. Sorry, technical problems. First, never work with children, animals, or internet connections. Right. So the pattern of the city, as the graph, as the animation will show, this is all of the cases through the whole course of the pandemic. Started actually in the west of the city, and you can see the date time at the top. Pretty quickly moved across the whole of the city. But over the course of each of the waves, and we're on our fourth, they all merge into one, fourth wave now, over the course of each wave gradually concentrates in the east of the city, principally decile 3, not decile 1, the most socially and economically deprived. Decile 3 have borne the brunt of this, largely work patterns, because there are a whole bunch of people that can't work from home. I can work from home, have been for most of the course of the pandemic, but if I work in retail or if I work in a warehouse, I can't, and I might have to get on the bus to go to work or train to go to work. So all of that has meant that the pattern of epidemiology across the city for the whole course of the pandemic has been starting fairly uniformly spread, but over each wave it concentrates in the most socioeconomically deprived. And as I say, decile 3 is the one where there's borne the brunt of this. Hospitalisation has largely tracked the underlying case rate, but also age structure and baseline health status. Because age structure is slightly different in the west than the east. Baseline health data is slightly different in the east than the west. So all of that is in, and there was a really interesting piece of work done in Paris that said 86% of those who were hospitalised occurred within the 45% most deprived areas of Paris. I don't think we've done similar analysis yet in Sheffield, but I'd hazard that would probably hold true for us too. Our pattern in Sheffield is largely akin to the pattern across across Yorkshire. The graph shows the very pretty graph, but basically shows the case rate across every local authority in Yorkshire, and it's a number of new cases, so that's not per capita rate. But if you look at the per capita rate, Sheffield is about average actually. Our pattern largely reflects socioeconomic profile and the economy structure. Of note, probably slightly higher case rate in, say, Barnsley than Sheffield. There are more people in Sheffield that have the type of jobs that you can work from home from. So the underlying sort of structure of the economy and the types and nature of jobs people have has made a substantial difference in some of this. So, but Sheffield's about average actually, which I'm not sure that's good or bad, but that's what it is. Lots say it's a bit crap in the UK, isn't it? Well, it is. There's no two ways about that. We've not had a good pandemic, and we can't shy away from that. But look in the context of this country, in the geopolitical context, look in the context of the nature of the economy that we've got, the nature of society we've got, broadly Western liberal economy. The basic strategy we took a strategy of suppression, not elimination. Whether that was the right strategy remains to be seen. Those are questions that will probably keep PhD students busy for about 2 decades, and will certainly keep the public inquiry busy for an awful long time. So all of that's in. We took gradually ramping up the measures that we implemented as a country. We did that as opposed to a sort of a pressing down on it on extreme measures very quickly. Again, these are questions that will need to be considered very carefully over a long period in time. Differentials, underlying social and economic factors, testing capacity. We test way more in this country than most of Europe. Timing for scale of vaccination. We started vaccinating at massive scale probably about 2 months before most of the rest of Europe. Natural epidemic curve, health system capacity, hospitalizations is clearly a function of how many beds per capita you've got. We've got less beds per capita than lots of OECD countries. So Chris Whitty says frequently, and I agree with him, what matters most is long run, all age, all cause mortality. That's the thing that matters most, and it's going to take us time to get to grips with that. But yes, it has been a bit rubbish in this country, but let's look in the long term as to how we've all done. There are poster boys that have done spectacularly well. Taiwan, for instance, New Zealand, done amazingly well, and credit to them. Whether or not we have done way worse than anywhere else remains to be seen, and we have to be accountable for that as and when that time comes. References, by the way, are kind of usually at the bottom of the slide, and you can chase some of those up at your leisure. So let's talk about the anatomy of the public health response. Who does what? When do we do it? What do we learn? Starting point for me was January 2020. I've not really done anything that's not COVID since then, sadly. We don't have enough staff to cover all the fronts we need to fight. Nor at the start did I know what fronts I would need to fight on. That our staff have gone way over the expected line of duty is no doubt. The overtime bill is enormous, and they're not getting any overtime. They all know that. Our staff have burned a lot of their personal well-being on a long-term committed response. Credit to their families who've borne some of the brunt of that, actually. And then there's what the team is. So people talk about the director of public health, but they're only as good as their team. I've got a great team. There's people who've got the term public and health in their job title, but actually the response here has been a whole team. Most of the council have had some involvement in this. Most of the NHS have had some involvement in this. Whole system, whole city, all of that kind of matters in terms of your starting point. We had a strategy. It was 3 words, about 7 words. Key people say, protect the vulnerable, reopen Sheffield. That was it. That was our strategy. There wasn't a 400-page document that went with it. That was the strategy. There were meetings upon meetings upon meetings upon meetings. I won't bore you with the detail, but the graphic covers some of the meetings, but there were a lot of them. There was a whole infrastructure set up to do some of this stuff. But basically, the strategy was this. It was a combination strategy. If you've not seen Ian McKay, who's a Brisbane virologist, his Swiss cheese model is now famous, and ours was a combination strategy. No single thing is going to be the thing that makes the difference. So our strategy covered prevention, managing individual incidents and outbreaks, minimizing testing delay, right the way through to enforcement compliance and focus on consistent messaging and simplifying communications and everything in between. We published it. If you want to look at the detail, it's there at the bottom. So, but no one thing made the difference. All of those things together contributed to where we got to, and as I say, others can judge how successful or not that will be, and I look forward to that time. The contributions of my staff directly have been stupendous, from leadership comms and humanitarian response, making sure people didn't run out of medicines and food if they were shielding, through to isolation, vaccination, supporting the NHS and social care response, balancing science, tech, clinical policy, strategy, ops across all domains of the totality of our response. And their input has been stupendous, and we would have been lost without them. So just underscore again, anyone who thinks DSPH do all of this are woefully mistaken. We're only as good as our teams, and my team have been awesome. But well beyond public health and people who've got that term in their title, there's an operational response across many parts of the council. We call it the COVID hub, and we've stood up a whole set of services to support the NHS with regard to vaccination. So it's not just the sticking the needle in the arm, though that is really quite important, but keeping car parks open, providing transport to people who can't get to a vaccination clinic, very detailed, deep communication and engagement with and through community and faith leaders across the city been supported. Support to the testing programs, which are various and multitudinous, a local contact tracing service, There's a whole range of operational machinery, which is basically the parallel image to NHS Test and Trace, or actually the parallel image to the government's Contain framework as set up locally. So the response is way beyond people who've got the word public and health in their job title. To be fair to government, it's been very well funded. That funding comes to an end at the end of March, and we need to think about what next after that. But that response has served us well, and we've basically nicked staff from across the council and repurposed them to be part of the COVID response. That has had a big impact. It's had a huge impact because, again, this just wouldn't have been possible with the 25 people that are my staff directly. There's probably about 130 people directly involved in some of that, and then many, many more hundreds kind of indirectly that bounce in and out of it from time to time. As I say, the team is way beyond people who have public and health in their job title. From environmental health, trading standards, we've done a lot of work on closing down scams, housing support, getting homeless people off the street, because I wouldn't imagine having COVID and being street homeless is much fun at all, right the way down to the fire service, who've done a huge amount of work in terms of delivering food packages to the vulnerable, supporting the logistics of PPE delivery. There was a time when we measured the availability of PPE to the social care sector in minutes and hours. It was really, really desperate at one point, and the fire service did an amazing job, repurposed their crews to deliver PPE. We measure it in months and years now, thankfully, but there was a time when PPE was measured in minutes and hours. So, and all of the stuff in between, that's basically been the business of the response, and that's still there, still operating, still working pretty well, actually. A few occasional operational problems, but mostly pretty well. In numbers, 1 million PCR tests to date, and that continues, 1 million. So well more than getting on for 2 PCR tests per person. 86,000 cases, 6 and a bit thousand people admitted to hospital, mostly people admitted to Sheffield Teaching Hospital, but 180 people admitted to Children's Hospital, children by definition. Sadly, 1,400 deaths, 800,000 vaccinations given, 23,000 contact tracing calls, and then kind of down this side, 2.5 million COVID grants, 2 million hardship payments, 2 million isolation payments, a huge, and I won't read the list because you can read that as you will, a huge operational response. And this isn't done by folk who've got the word public and health in their job title. This is done by a whole range of other people, and credit to them for doing it. It's taken a huge amount of orchestration, organisation and coordination, but when we talk about a whole system response, then it's that basically. So some big numbers in there in terms of the response. I've been a bit busy, that's my diary, for probably about 6 months ago now. Sorry if I didn't get to your meeting. Basically, you need to make a judgment about who you piss off least by not attending. And the triple booked, back to my diary, could only see the sort of the 9 till 5. It was usually about 7 till 6, 7 till 7 most days. And sorry if I didn't get to your email quickly either. It was lost in the 500 I get every day, and I read it between breaks in between meetings. So and all of my team are all in exactly the same position, and actually pivoting to online has made it all worse because it's easier to squeeze in just another 15-minute Zoom meeting or just another 15-minute team meeting. It's been busy, and then talk about earning your keep. Well, this has been the 2-year period where we've all had to earn our keep. So we're 22 months in. Some thoughts on leadership in this context. You're going to have to earn your keep, and you can't be everywhere. Just deal with it. There's nobody going to ride to the rescue of public health teams in this context. Thanks, Andrew Lee, for that particular line. He told me that really on. Said, Greg, my overriding experience of disaster management is nobody rides to the rescue. He was dead right. Much as we've tried hard to get people to ride to the rescue, it's been tough. We don't have enough staff. As a team, we've probably done the work of a team twice as big as us. That is as it is. When these things happen on your watch, you can't not drop everything to respond. As I say, at the start we didn't know what fronts we were going to need to cover. Very deliberately made leadership not a one-person job. Very deliberately pivoted away from kind of the heroic leadership model to distributed and system leadership. And again, I think that served us well. And I'm at pains to say, the DPH doesn't do all of this stuff. The DPH doesn't lead all of this stuff. We collectively do it across the city. And that has, I think, made a difference in kind of helping coordinate some of this stuff. And The playbook says command and control. My experience says you can't command and control some of this stuff. You have to have good relationships and trust, and you have to enable people to make judgments based on the view on the ground as they see whatever that particular context is at that particular moment. So really, really difficult to command and control some of this stuff in my experience. That said, you do need some form of command and control infrastructure. And the policy keeps changing. That was from March to March, and there were the major policy shifts all up. I think there are about 190 policy shifts, and I can't keep up. It's just been really difficult to keep up with some of this stuff. And again, you can't kind of see the detail, but anyone that can keep up with the policy over the period, well, good luck to them, because it's proved somewhat difficult. So I said earlier, we can't control it, so I haven't tried, but I have had some fundamental red lines. So our basic strategy is as it was: keep people safe, protect vulnerable, and enable Sheffield to run. There has been conflict. Occasionally, we've needed to make political judgments. Occasionally, I've made small p political judgments. Occasionally, I needed to ask my councillors to make big p political judgments, sometimes especially when going against government advice. And I'll come on to one or two examples in a sec. Throughout, we've stuck to core public health principles. In this audience, I won't need to bore you with what they are. Worth saying that many of the core tools of controlling the pandemic are not in my control. Testing is a government enterprise. Contact tracing, for the first 8 months, was largely a government enterprise, and the national comms strategy, not in my control. We've done what we can locally, but not in my control. Basics of leadership. Again, I won't dwell on these too much. Have principles and the strategy and articulate them regularly. Don't try and command and control. Adopt the sort of team of teams mentality. It's worked pretty well for us. Have good intelligence, both in terms of data, but also frontline intuition. What are the real world insights, and what are they telling you from the clinical coalface, from the volunteering community and faith sector, who will just see people and deal with context way before it turns into data that lands in a shiny graph on my desk. Understand your enemy, in this context SARS-CoV-2, how it works, how to control it, what works. We know that. It's been pretty constant throughout, actually. Get out of your silo. Don't spend too much time talking to people who are in your silo. Single constituency responses don't work, and one of my personal things is get out there, be visible and be trusted. You can decide whether or not you trust me or not. Hope you do. Many wobbly tin hat moments. PPE was the first one. As I say, we were initially measuring our PPE supply in minutes and hours, not so much now. Initially, the PPE advice was the PPE advice to the NHS. After a lot of pushing, that got widened to social care, and after a lot of further pushing, all those who weren't social care employees but did have intimate contact with people that also probably needed PPE. Sheffield was a hotspot really early on. It was a hotspot, and it's because Sheffield Teaching Hospital were doing a community testing programme a long time before the thing that we now know, Pillar 2, was in existence. If you're lucky, find, and as a result, Sheffield Hospital did find a lot, therefore we became a hotspot. At one point, Sheffield was the epicentre of deaths for the whole country, and I remember the Guardian headline vividly. It was because we had many very large care homes in Crabtree and Furvale, and a high concentration of vulnerable old people there. Sadly, lots of them lost their lives, but that, looking at the geography at a very small scale, that made Sheffield, or a part of Sheffield, the epicentre of deaths for the whole country. Schools, lots of tin hat moments about schools, when and how to reopen after the initial lockdown, when and how to reopen in January half term. I've had seen emails that education unions have told me I'll be responsible for harm that comes to teachers. There are costs and consequences in all directions here. Schools do good things for kids, and all up, schools are low risk settings, and I'm not so worried about COVID in schools. I am worried about COVID in care homes. So many tin hat moments on schools, and a few more. Going against government on asymptomatic testing, with mass testing with lateral flow device tests, especially in the early days when we were really unsure about the properties of lateral flow device tests. So I had lots and lots of tin hat moments on that context. Communication with everyone about everything. The rules keep changing. 280 changes in the rules, apparently. I hope you've all read them and can all keep up. I couldn't. So early on, we said we're going to sort of strip away the complexity and focus on the core principles of disease transmission that underpin all of the rules over umpteen pieces of guidance. And we've never focused on enforcement of the rules. We've always focused on consent and consensus and focusing on the core principles, because to enforce, you need cops on every street corner, you need cops on every bus, and it's not going to happen. So we've always focused on consent and consensus and try and simplify and get to the core principles. We focused a lot of our comms on positive deviance. Most people are getting vaccinated. Most people are wearing face masks. Well, at the moment, most people aren't. Apart from you, you're all wearing one. I'm not. But and thank you for that. So we focused a lot there. The national stuff sometimes hasn't helped. Eat out to help out, for instance, didn't help us. Trust in the messenger is key, and that's my experience. And a lot rests on trust in the messenger. Note to self: be careful what you say. Your words and my words have been twisted, and lots of polarization of positions. Here, I did a session for the Science and Technology Select Committee, and I was asked a question about risk of transmission in the hospitality sector. I forget my exact form of words, but it was along the lines of, one, the hospitality sector has tried really hard to run COVID-secure environments, and this was in middle to late, summer-ish, maybe May to June type of time, when we were coming out of a lockdown. And my response was, one, the hospitality sector tried really hard to run COVID-secure environments, and secondly, it wasn't at the top of my risk radar. What wasn't reported was at that time, because largely the hospitality sector was running a reasonably skeleton service, which was translated by the Daily Mail as Sheffield top health chief backs Mail's campaign to get Britain's boozers open, which wasn't quite what I said. I was rather more measured, but note to self: be careful what you say, because your words do get twisted. Learning lessons. Early on, things that were said to me: you must lock down the city. This was said to me in February by lots of people. Yes, I agree. They don't have a power to do it. What does it mean? And I have no legal authority on which to do it. So testing. Two, firstly, early on there was a significant lack of testing capacity, with the notable exception of Sheffield Teaching Hospital. But we couldn't, even with that amazing capacity that was there, and credit to them because they did do an amazing job, didn't have the capacity to set up a big community testing service. And my second issue around testing was the introduction of lateral flow device testing, with not much thought given to protocols and QA, which kind of matter a lot. So yes, but contact tracing, we'll set it up now. Credit to some community contact tracing in the room. Credit to them, they did do some of that stuff early on. Just didn't have the funding to do it, actually, and actually didn't have the testing capacity to do the job properly. And obviously, they're kind of had no authority to make people isolate, and that comes with economic consequences. So yes, but you must enforce the rules. I've talked about that already. We can, and I've used the term advisory there, we can knit you some PPE. All sorts of companies were repurposing themselves to produce PPE. I was overrun by offers of PPE. Standards, QA processes and mechanisms, and mixed messaging on comms I've picked up. So lots of interesting things were said, and there's always a number of sides to the story. Things that didn't work out so well: you don't have fundamental control over some of the tools. That's important. Very centralized strategy. The UK is one of the most centralized states in Europe, possibly the world. We ignored local expertise until far too late. Data has been a massive issue. It took 4 months to get person-level data on a notifiable disease to the person who was legally responsible for a response to the notifiable disease, aka me, or more to the point, my team. 4 months. That was a huge issue. It's still, I mean, data on testing is largely now sorted, but there's a whole bunch of other data stories that still aren't sorted. PPE, I've talked about. A little bit, so I won't talk more. Comms, ditto. Testing, but no clear strategy for testing. There still isn't a very clear strategy for testing. We've done our best on that, but different bits of the testing infrastructure haven't got a clear national strategy on testing. Isolation was a big deal. Fine for me if I'm told to isolate, that's fine. I don't care. I'm going to spend some more time in my spare bedroom. But if I work in a warehouse and I'm on 0 hours contract, I ain't going to get paid, and 500 quid for 10 days ain't going to feed my family. That matters, and matters a lot. Lastly, changes to the National Public Health Agency during the middle of the worst public health emergency of our lifetimes have taken out some of the capacity of the organisation. PHE have done an amazing job. This was their finest hour, and I hope UK Health Security Agency can continue in the same vein that PHE started and thus far are doing so, so credit to them, but perhaps not the wisest thing to change the Public Health Agency during the middle of a response. Things I wish had been different, earlier mask up messaging. I think I wished we'd gone there a bit earlier. Earlier big scale community testing with local lab capacity. I wished we'd been there. As I say, the SDH stuff at the start was hugely helpful, but the hotspot consequences took a bit of managing. And early on, I think we went into this with an infectious disease playbook. We arguably underplayed social and economic issues, cramped, overcrowded housing, low pay, insecure contracts, etc., etc. That had a big bearing, and still has a big bearing on enduring transmission, which I think is the current buzzword, but basically endemic transmission of an illness, which will be with us for some time to come yet. Led by the science, SAGE has been incredible. And all of the subgroups of SAGE have been genuinely incredible. Hasn't stopped lots weighing in with other views, and sometimes that takes a bit of managing. There are plenty of examples of not following the science, not following the rules versus our ability to follow the rules. People will be behaviourally fatigued. Not true. Stephen Riker's thread at the reference to the bottom was a useful set of examples. Saw this quote recently. If you believe in science, then you're doing it wrong. Science is not a god or a unicorn. Science is a tool that can be used and a process to be understood, and it helps accumulate a body of knowledge, but is housed within socio-cultural enterprise. So yes, we can be led by science, but science exists as part of a bigger construct, so it's important that we remember that. Polarization, politicization of science was a big issue, certainly a big issue. Politicization and different interpretations when the science was clear and when it was less clear, and the extent to which the precautionary principle is in play and how far to push it. Face masks was a good example of that. Schools, ventilation, face masks, how you do the prioritization of vaccination, all examples of polarization and politicization of science. And it's been difficult, and still is quite difficult actually. What COVID taught us, our poorest communities have multiple risks, and that has left them unprotected when the virus spread into those neighborhoods. Lockdown measures have less effect when people have to leave their houses to survive. There's a false trade-off between health and the economy. I think that's a learning, hopefully, that we won't have to relearn. The NHS and care system is world-class and has responded to a pandemic unprecedented in its history. And we've also had an astounding ability to mobilise across the whole of local government, voluntary and community sector, and civil society. All that said, the pandemic has shown up some significant cracks in our society. Lots of mistakes that we keep repeating. This was an article in The Atlantic, I think it was. And again, I won't read those in the essence of time to get to the end. Lots and lots and lots of lessons. The Institute for Government was very interesting and helpful. Two that I would, one I would emphasise here is the relationship between central and local government. It can't only be local government, it can't only be central government, it has to be both, and that's a critical lesson, I think, going forward. Lots of parliamentary inquiries, a few select committee inquiries, National Audit Office and others thus far. Again, I won't read because you can read those at your leisure, but lots and lots of emerging lessons. It's probably too early to start learning lessons given that we're not done yet. Greg, why don't you shout at the government and call them out? There's a tricky issue for someone in my position here. There's sort of a balance of shouting from the sides or from the centre of things, or getting things done by change and getting change done by doing stuff. If you shout, sometimes you get kicked out, and sometimes you're able, by being in the room, sometimes you're able to shape and influence, sometimes you're not. And there are plenty of examples where being in the room, we've shaped a better response than not being in the room. And obviously, of course, knowing when to shout, both in public and private, and who to shout at, and when to whisper and who to whisper at is critical. Most importantly for me, I have to be accountable for my actions. We all have to be accountable for actions, and that time will come when we have to be accountable. The post-March analysis will come. It has been a public health emergency, so guess who's going to get kicked at the end of it all? I've saved all of my emails, and I know exactly who was said to what, when, and whom. And the rest I've talked about already, so I won't repeat all of that. Eventually, it's going to be over. The long shadows bit, we know now, we've had it demonstrated to us again, that structural issues in society massively outgun individualistic approaches to behaviour. There has been more COVID in some communities than others on account of various things. That has consequences. We've got a population that's frailer, drinking more, exercising less. I'm one of those. And all of that's unequally spread. The indirect social and economic impact of the recession that may follow. We appear to have escaped the worst excesses of a recession thus far, more in the east than the west. And the pandemic has accelerated inequalities that were already there. The pandemic has also accelerated the fundamental flaws in the local government funding position, which will, is not just a here thing, that's an everywhere thing. Recovery, we're going to build back better, and we're going to level up, both of which are marvellous, and I hope to see that happen. So financial hardship's been concentrated in the areas with highest poverty. Levelling up is a good thing, but it's difficult to define, and it's fair to say that levelling up in the way it's played often is disadvantaging to inner city areas because they don't get a huge priority on the current levelling up agenda. We can't have levelling up without an effort to rebuild local government services, civil society locally, and increasingly I kind of use a line that would treat health as a national infrastructure project, a bit like HS2, which I perhaps shouldn't have put in this particular slide given what happened over the last few weeks, but you know what I mean. Think of it as a giant infrastructure project with similar timeframes. We hopefully won't have a growth-led recovery, because if we have a growth-led recovery without getting that right, I think that will lock in the economic lessons of the 1980s, and I don't think that would be a good thing. I'd prefer a health-led recovery, but you would expect me to say that being a bloke in my position. But increasingly reframing the value of good health to society, both kind of, it's intrinsically good in its own right, but it's also a social justice issue, and it's also a good thing for a productive economy to have a healthy society. Takes me right back to the starting point, so I won't dwell on those slides again. And the inequitable distribution of those things are the things that we really, really need to think of as we come out of the pandemic. This is my third pandemic. There's going to be another one, climate change and zoonosis, that will come from that. Don't know how prepared we will be. But SARS-CoV-2, COVID-19, 5 million deaths nationally, about 1,400 in Sheffield, there or thereabouts. HIV, about 40 million deaths. Sorry, it's 50 million deaths. Swine flu, 18 million deaths. Tobacco, so COVID killed 1,400 in Sheffield. Tobacco kills about 1,000 every year, year after year after year in Sheffield. Numbers coming down because prevalence is coming down. Actually, prevalence of smoking in Sheffield is pretty good. But let's not forget the things that we already know about. And it's not over yet. The one thing that I would encourage you all to spend a minute doing is looking at Mike Ryan, that fella. It was when asked a question really early on in the pandemic. Tell us about what we can learn from your experience fighting Ebola in Western Africa. And he said the most important thing is, if you need to be right before you move, you'll win. But he basically said you need to go earlier than you want, you need to go harder than is comfortable, you need to wider geography than the data says, and a much, much, much higher level of uncertainty. So we have a new variant of concern, not yet reached Sheffield, but undoubtedly it will. Remains to be seen how significant and consequential it is, but we're treating it very seriously. Despite all of that, the pandemic's definitely not over yet. The legacy, nearly done. After the cholera monuments of 1830s, we built a monument still, well, I don't know where we are now, over there somewhere, I think. The master cutler is named on the pinnacle, but not the other victims. But the cholera epidemic exposed the cracks in society and led to the public health acts of the Victorian age: clean water, slum clearances, waste management, don't yet know what the legacy of COVID will be, but it's up to us to try and engineer the right one. So I'm done. Thank you to those I nicked slides off, particularly Kev. He's not in the room, but I suspect he's watching. Thank you to those who I've learned from over the years, more years now than I care to admit. Thank you to my team who have been stellar, undoubtedly. Their finest hour, 22 months in and counting. One person in particular, Louise in my team, sadly died. Sorry, I thought I'd do this without crying. Sadly died. She died suddenly a few weeks ago. Louise has been amazing in all of this, and I particularly want to pay credit to her. The only person that can look cool and sassy wandering around the town hall with a shopping trolley. And I shall leave you there, and thank you. I shall see what questions you have.
Brilliant, thank you, Greg. So we've got time for a few questions before I believe you have to go to another
Omnicom briefing.
Yes, indeed. So what we're going to do is we'll interchange questions from the room with questions online. So Dan, if you could open up the chat, and Lydia's going to filter questions in the online chat. So any questions from people here? Don't be shy.
Don't be shy.
Really interesting. I was wondering how much influence do you really think that the social media aspect of all of this has had in terms of, I don't know, making the government or yourselves do things that you might not have done at the stage that you did it?
Huge, probably unmeasurable, certainly difficult to measure. Good and bad. Sometimes there's a sort of the white heat of social media says you must do X, when X clearly isn't the right thing to do. And kind of holding the line against that has sometimes been quite difficult, and it's caused me one or two tin hat moments when you put your tin hat on and you go and hide in the corner, and or you just turn Twitter off for a day. So there've been plenty of that. The upside is that you sort of just get insights that you might not otherwise get. You know, I tend to talk to public health people. That's where I get my sort of that's where I get my constituency from. But social media is kind of a lot broader than that. So you tend to get insights that you might not otherwise get, and perspectives on the world that you might not otherwise get. And actually, new papers, new science, that just randomly come into my timeline. I think, oh God, that's going to be useful. So it has upsides and downsides. One thing that has been particularly difficult about Twitter is vaccine misinformation. Particularly easy to spread vaccine misinformation on Twitter, and that's done harm. And there are consequences to that harm. But sadly, there's no accountability. So upsides and downsides, but probably impossible to actually quantify the impact of it, much as I'd like to wish I could, but I don't think I can.
Great, thanks, Greg. So we've got a question from somebody online, Eduardo Gomez. Can you illustrate the trade-off between health and the economy?
It's sort of in a non-COVID context, is sort of the Scottish government, and I must chase this down, but did a piece of analysis 2 or 3 years ago that looked at the constraints to economic growth. Number 1 was skills, number 2 was health, and number 3 was caring responsibility. Those people that aren't at work or are suboptimally at work because they've got caring responsibility, often secondary to somebody with poor health, not always. And if it's sort of to sort of simplify it, to perhaps oversimplify it, as I say, if I develop breast cancer or have a diabetic heart attack age 50, I might not go back to work. You know, aggregate so that in the individual level, that's clearly bad for me. Bad for my family because I earn the income in my family, but makes me more. I pay less tax, and obviously I claim more benefits. So that's bad for me individually, but also aggregate that up across a whole population is bad for the economy. Hence, finding ways to improve the health of populations and individuals within populations is good for their health, most obviously, but also good for the economy. COVID, at times, people sort of give this, well, you need to open up society because lockdowns are bad for the economy. There's no two ways about it. Lockdowns are bad for the economy. But if you open up society at the wrong time, all that happens is unmitigated spread of a virus, unmitigated pressure on NHS and social care services, and then you end up having to go into another lockdown because the NHS is at risk of being overwhelmed. That's even worse for the economy than not being locked down, than the lockdown continuing as is. And people say there's a sort of a trade-off between health and the economy. I just don't think it's as simple as that, to be honest. I think it's a good bit more complex, and there's a fair amount of data. Institute of Fiscal Studies and others have published a fair amount of data on the sort of the how the two things are interconnected in a COVID context, but in a non-COVID context, it's much more straightforward. Hopefully that vaguely answers.
Great, thank you. A question here.
With microphone, seeing as it was so booming for the people online last time.
Thank you, and thanks for it to you and your team for everything you've done. I was really heartened to hear you talk about the importance of collective leadership. So two things. One, how did you keep your team together, given the diary that you've just shown us? And also, what does Greg Fell do for self-care?
So I'll answer it in reverse order. On the latter, listen to really loud death metal. Occasionally go for a run, and I'm trying to start climbing again, but not with much success. So that's the sort of the self-care sort of stuff. On the keeping the team together, it's been really hard. A lot of them have burned substantial components, a substantial part of their well-being, and they're committed and ongoing response to COVID. And well-being has suffered. Actually, family well-being has probably suffered as well. I hear less about that. I hear a lot about the individuals in my team. Being online is actually harder because you're all stuck in our spare bedrooms, and it's lonely, to be honest, and you don't have the sort of corridor conversations that you often have with people whilst you're waiting for the kettle to boil and all that kind of stuff. You've got to make a conscious effort to teams people. We don't phone people up anymore. We teams people. It's hard, but setting up structures where we do some of that, almost a social online, where you don't have business meetings, you just have a chat with people. Done a little bit of that. I think it's been moderately successful. Team might think differently, I don't know. One of them's in the audience, so she might think differently. And just kind of allowing time for people to just unload of all of the difficult stuff that's happened. But I can't shy away from the fact it's been incredibly grinding, incredibly difficult, and there's a vague light at the end of the tunnel, but it ain't quite here yet.
Great, thank you. Another question from one of our guests online. Vaccine hesitancy. How do we get the Sheffield rate higher?
I don't think we can, actually. It's worth saying we've got rates of vaccine coverage that you could only dream of in standard seasonal flu years. And we got vaccine coverage in the most vulnerable, so the 80 plus is well north of 95% now. But it comes down as you come to the younger age groups. Genuinely don't think you can. I think there are a group of people who are somewhere between hesitant and resistant. And the hesitancy strategy is just talking to people about their fears, their concerns, what's going on for them, and just addressing misinformation at individual and then at sort of mass communication level at every available opportunity. There's still plenty of misinformation out there. The resistant and the refusers, I don't think there's anything you can do on that, to be honest. Genuinely don't. And I rarely go toe-to-toe with anti-vaxxers because it just creates noise and confuses everybody. So the other strategy is making it easy for people. So we've got pop-up sites all over the city. I don't even know where they all run these days, but the pop-up sites all over the city, you can walk in, you can get a COVID vaccination. We've got a van that does mobile vaccination, and I'm told that last week we vaccinated a 90-year-old bloke that walked out of Sainsbury's that wanted to know what the van was about, so we told him, and he said, oh, I've not got around to my vaccination. Sit in this chair, and he was really pleased. He kind of partly not got around to it and partly thought he'd missed his opportunity. So that's what we're doing. What we find is that each time we opened up a new age cohort, so we started with the 80 plus, then we went to 70s and 80s, and then we went kind of down the age cohorts, people came in their droves And then it just got that little bit harder. You get sort of diminishing marginal returns territory. So then we did pop-up clinics in more convenient locations than they'd been historically available. And pop-up clinics kind of, you get to people that they're coming back from the shops or coming back from work, coming back from whatever. And then we get a van, and the van gets to people that we just wouldn't otherwise get to. So two strategies, making it easy, and just directly talking to people openly and honestly about what we do and what we don't know about safety and efficacy of the vaccine. But I don't think we're going to get coverage. Sadly, much as I really, really want to, I don't think we're going to get population coverage more north of 75%. If we get there, I'd be hugely happy. But I think it's a struggle to get much beyond where we've got. It's not for lack of trying.
Great, thank you. We've got another question here from Nick.
Hi, Greg. That's a tour de force. Congratulations. I'm sure John Pemberton would be proud. That was really, really good.
Hope so.
Thank you very much. I've just got 2 points. And you sort of mentioned it a bit in the vaccine bit. And I think, and you mentioned it throughout, but the importance of volunteers in the voluntary sector
Huge. Yeah.
is something I think really has to be looked at very, very carefully, particularly, I guess, around vaccination as well, and all those issues around education and computer competence and so on.
I agree. Impossible to understate the importance of volunteers in that. We have made great play of the NHS has done a stupendously good job around vaccination, around COVID, as it does around vaccination for everything else, to be honest. But let's talk COVID. NHS has done a stupendously good job, no two ways about that. But hasn't done it by itself. It's done it by a sort of small army of volunteers, a small army of people that do the logistics, make sure the car parks clear of ice. And that was happening this weekend just gone. There were people shoveling ice from car parks to make sure we could get boosters delivered to people. It's impossible to understate that. And it's the sort of the stuff that's upstream of the needle getting stuck in your arm. It's been hugely, hugely impactful. If we can learn some or all of those lessons and apply that to routine vaccination and screening for all sorts of other things, I think we'll be doing well. Interestingly, and here's an interesting aside, talking to Jenny Joyce, who's a clinical director of Foundry Primary Care Network, and Jenny said they didn't, they employed their volunteers. They didn't have volunteers. They employed them. They gave them a temporary contract and a job. Some of those volunteers have now gone on to get paid employment. So credit to some people who've kind of used their ability to give people opportunities for jobs that they wouldn't otherwise have had. But all of that has been hugely important and impossible to underscore.
Great. Somebody's asked about the future of Sheffield city centre, worrying that it seems derelict or unvisited. Probably
a bit beyond my pay grade and or my area of expertise. John Lewis is gone. I don't think he's coming back. But the what's happening to the city centre and how we rejuvenate it is probably not something I'm terribly competent on. So I better not say much. Let's have one more question from in the room and then one more question online. Could I go over that? And could you repeat the question? Oh, sorry, yeah.
And in terms of the other element of the recovery from the acute infection, what do you think the role of public health is in influencing how any opportunity that long COVID has on kind of complexity of multimorbidity pathways?
So the question was about the role of public health and others around the sort of the long COVID implications. There's a lot of it about. I'm not sure is my off-the-cuff answer. There's something about getting a decent handle on the epidemiology of long COVID, and ONS actually have done the best work on epidemiology of long COVID today. They've done some excellent work in that space. My team have done a reasonable chunk of work on what's known around epidemiology of long COVID, but that was about a year ago now, and things have changed since then. So we might need to do a little bit of sort of health needs assessment-y type of stuff on what's known and what's not known about long COVID. The other role for public health, I think, is sort of making sure, and I don't worry so much about this in Sheffield, having talked to some of the people doing the work, but making sure the model's not a fairly narrowly constrained medical model. Benefits, employment, social support really matter in all of that stuff. So what we've got is a brand new health need, I'll come on to that, but a brand new health need that didn't exist 2 years ago. Well, now's an opportunity to get a really holistic model to addressing that health need before we get the wrong kind of thinking cemented in. The caveat to the brand new health need is, arguably, you could just say this is a form of disability and functional loss, like loads and loads of other forms of functional loss and disability. So treat it in the same mind. But the challenge is, one, understanding how much of it there is and what that looks like in any given population. And there'll be sort of gradations of severity and all that kind of stuff. And secondly, the challenge is getting the right model, because a hospital-centered model is going to be necessary, but nowhere near sufficient. Credit to those who are doing this work in Sheffield, because I think they've got nothing like a hospital-centred model, but that may be the case in other parts of the country. So I think the public health role is making sure that the sort of model is fairly broad and holistic. But clearly we're not going to be in the business of treating people for long COVID, term used advisedly.
Great, thank you. And one last question. So this is from David Buck online. Will COVID change the role of the DPH in the long term?
Thanks, David. I don't know. Clearly, the role of the DPH and their teams, but much emphasis is put on the role of the DPH, have some sort of rock star status at the moment. That isn't going to last. Clearly, we'll capitalise on it whilst we can, but it clearly won't last. But so I get asked questions on the DPH gets copied into all manner of emails about all sorts of things that are way beyond my competence at the moment, because I'm sort of a known figure. So I quickly said, well, I don't know much about X, Y, or Z, but here's who you do need to talk to. Will it fundamentally change the role of the DPH and or public health in local authorities? Probably not, but if anything, it will cement the role of the DPH as the person that sort of leads the city's response to health, term used advisedly, by which I mean health, not healthcare. And I don't think the fundamental role will change that much. I think, but I may be wrong.
Right. Well, again, thank you very much, Greg. And it's been absolutely wonderful to hear your presentation. Tons and tons of stuff there to get our teeth into. And you're happy for us to circulate the slides?
Yeah, absolutely.
Right? Yeah. There's tons of links in there to follow all of those stories. So thank you very much, Greg.
Thank you.
And, if you joined online, thank you for joining online. If you're here in person, we've got drinks outside, so please do join us.